Reading at the moment. So I'm going to be teaching you about, well, talking about renal disease in pregnancy. So there's quite a bit to go through. So we're going to be covering some basic physiology, chronic kidney disease in pregnancy, dialysis and renal transplant in pregnancy, and discuss some of the antenatal management that you will need to consider. And also we'll talk about AKI in pregnancy, and we'll do some case presentation studies if we can. So, so I'm going to open it up to all of you. So what do the kidneys do? Amelia and Ebbs, I heard your voices already.
No,
um,
um,
go for it.
they do sort of control of fluid balance, excretion of waste, acid-base balance.
Good. Anything else? Any
Electrolyte
hormone?
balance,
Yeah. Anything about any hormone production, any activation of anything that they...
erythropoietin for
Good. Yeah.
RBC.
And vitamin D, bone health sort of thing. That's what they do. So, yeah, basically what you've all have said already. So, important class of drugs and metabolites and toxins. So, particular drugs that we'll use in our practice, in particular obstetrics, like magnesium, insulin, all those sort of things are very really excreted. So, just something to be mindful of when you have AKI or chronic kidney disease. Electrolyte imbalance, as you mentioned, acid-base status, hormonal production, particularly hypoerotin, as you mentioned, BP regulation, so the renin, angiotensin aldosterone system, and activation of vitamin D, which is important in bone health and metabolism. So pregnancy adaptation. So can I just see if it goes? It's just quite annoying. I'm just see if it goes. Can he? Has it worked again, or is it gone off again?
No, it looks good.
Okay, fine. So pregnancy adaptation. So in pregnancy, we get particularly the kidneys get increased blood flow. There's an increased total blood volume increases by 50% in women when they're pregnant. So as it corresponds, you get an increase in renal blood flow, and with that you get increased glomerular filtration rate. So with that you get reduction in urea as well as creatinine in the first trimester and the second trimester, then it starts to go up in the third trimester. And there are also other systemic changes that goes on. We also see that there's increased glycosyluria, so the renal threshold for reabsorption of glucose decreases. And that's mainly mediated by the placental lactogen that happens from placenta, and you get increased calcium secretion and decreased reabsorption of uric acid. You do get some general proteinuria during pregnancy, which is a bit more than you would do if you weren't pregnant, but the normal range would be so a PCR of basically less than 15 or 15 basically. So you also do see some physiological changes, particularly with the kidneys. They do increase in size. You do get more of a sort of a right-sided sort of hydronephrosis. You do see a slightly more increased dilatation of the renal pelvic calcareal system, usually between 10 to 20 millimeters is a normal increase that you expect to see, not often due to relaxing ureteric smooth muscle and induced by progesterone, and compression of the uterus by the enlarging uterus or iliac vessels, and particularly get that dextral rotation more on the right side. So we mentioned this already. So so Ebbs, what happens to serum creatinine in pregnancy? What do you expect to happen?
So you mentioned that initially it falls along with the urea, and then later on it see it rise.
Yeah, so essentially that's what happens, and the same urea follows as well. And it's very important to note that note those sort of changes, and a lot of our colleagues that don't work in obstetrics as much will not recognize that, and often realize that I know a higher that have a basically compared to pre-pregnancy people who are non-pregnant with regards to creatinine levels, particularly in postpartum period. So it's important to remember that it does go up, but also that a creatinine of basically more than 76, 78 in pregnancy is slightly higher than expected and is an abnormal range. So urates do go down, but they do go high, increase, particularly in the further part of the latter end of the third trimester. And plasma osmolarity does decrease because we got an increase in plasma volume. So in chronic kidney disease, so we all know the stages. We've all gone through this in med school. So stage 1 stage is up to stage 5. Stage 3 is split into two categories. Now in stage 1, we all, I hope, have an EGF more than 90. We don't all have CKDs. Those people who have stage 1 often you have to have some mild renal impairment, whether that's microalbuminuria or an actual known diagnosis of renal disease to have stage 1 CKD. Just something to be mindful of. Different degrees of kidney impairment have different degrees of impacts in pregnancy, and also pregnancy will impact them differently as well. So about 3 in 100 women of childbearing age will have stage 1 and stage 2 chronic kidney disease, and often they have persistent albuminuria associated with essential hypertension. 1 in 150 women of childbearing age are affected by stages 3 to 5, and often these women have reduced fertility, and we don't often see them often in our practice because of that reason. And they often have increased rates of early miscarriages, and in pregnancy these women are often less common, as we mentioned. And 1 in 750 pregnancies is complicated by stage 3 to 5 disease. So what are the common causes of primary kidney disease in a woman of childbearing age? Anyone? Any guesses?
Could it be something like polycystic kidney disease?
Yeah, definitely. Polycystic kidney disease is one of the top 5 common causes in a woman of childbearing age. Anyone else? You get I'll do some CBDs for you guys if you answer these questions.
Diabetes?
Yeah, diabetes common. Yep. Anything else?
Other autoimmune diseases like lupus or.
Yep.
Hypertension?
Yep, exactly. Hypertension is very common.
Pyelonephritis?
Pyelonephritis, yeah. There's one group that's quite big that you might have learned in med school, the glomerular nephritis. So it's glomerular is one of the most commonest causes. So glomerulitis it can get primary and secondary causes of glomerulitis. So essentially, what it is you got renal damage at the tubular structure, where you get in the basement membrane of the nephrons, basically, and it can be caused by autoimmune conditions, viruses as well, and also the classic group B, so group A strep infection that you often get can cause it at times. So those are the common things. Other things that are quite common is those who have reflex uropathy, and often that's a hereditary condition at times, so it's important to know about that as well. And then obviously drugs, and then you got the idiopathic cases as well. So for some key notes about some of the causes, so in glomerulitis, patients are often on immunosuppressants. Now, it depends on what sort of type of glomerulitis they have. So, you got the rapidly change glomerulitis, as well as the minimal changes as well, and focal changes. There's so many different things. I wouldn't get into it too much, but there are it's a variety of different types of glomerulitis. Generally speaking, if it's rapidly progressive, it's really bad. That's what you got to remember. So often in glomerulitis, there is an increased risk of fetal loss and preterm delivery, about 1 in 5 women. Less than 10% have a reversible cause of renal impairment, and 3% have a progressive decline in kidney function related to pregnancy. Again, something you mentioned about vesicular reflux is often the damage occurs in childhood because they're often born with it, and they often are on prophylactic antibiotics, and often people have had transplants as a result of this as well. But it's also important to remember that some forms have autosomal dominant inheritance, so you need to often refer them to FMU just to make sure there's no evidence of hydronephrosis, but often that's picked up in the 20-week anomaly scan anyway. So diabetic nephropathy, as we know, is a quite common cause of end-stage renal disease in adult populations. And diabetic-related maternal complications is often double with associated nephropathy, and 30% of people have preterm delivery, often iatrogenic, and 50% are hypertensive. SLE, as we mentioned, we're not going to go through this in detail, but it's often it's autoimmune condition, and you get significant proteinuria, and you also do get hematuria at times as well. And there's a high risk of spontaneous miscarriage, particularly in the first, second trimester, and fetal death, and you get associated preeclampsia and preterm birth, and of course restriction are UGR babies as well. So often women will have serial scans and will have 4-weekly urine as well. Adult positive kidney disease, as it's the most common inherited kidney disease, autosomal dominant. People often have distended abdomens, and patients are at risk of other conditions as well. So it's very important when you see these patients that you ask about if they've had a screening for cerebral aneurysms. And often there is a screening program for those who have adult polycystic kidney disease and the high risk of intracranial hemorrhage, particularly if they have got known aneurysm and they are attempting a vaginal birth and actively pushing. Often the people have valvular heart disease, and particularly mitral regurg and prolapse. Liver cysts and abdominal wall hernias are also quite common. And UTIs are quite difficult to treat in adult polycystic kidney disease because often the UTIs are bacteria gets into the cyst, and it's often antibiotics don't penetrate the cyst that well to treat it. It's often they're quite prolonged course of antibiotics. So what are the effects of pregnancy on chronic kidney disease? What do you think happens to people when they get pregnant and they have non-renal impairment? What happens to the kidneys? Do they do well? Anyone?
I imagine. Oh, hello. Would it potentially do worse? Because
Yeah.
if an existing renal pathology, then pregnancy puts a lot of stress on the systems, especially more kidneys, kidneys and heart. So.
Yeah. So just think of it, keep it simple. So yeah, exactly what you've just said. So anything that's any organ that's going on in failure that are quite vital, particularly the heart, the lungs, the kidney and the liver, if you they're already not working that well, so you're adding additional strain to those organs, they're not going to work better. They're going to get worse, and it's an increased risk of morbidity and mortality for the women. Same thing with kidneys and hearts. As you know, you're adding extra volume, and you got an organ that's not filtering the blood well enough, so you're going to get accumulation of fluid. And same thing with the hearts, you know, you're not pumping blood around the body that well, so you get accumulation of fluid in the peripheries or in the lungs. With livers, if you got increased fluid, you cause pressure on the cirrhotic livers, you get increased portal hypertension, and you get variceal bleeding, and there's 10% mortality with people who've got liver failure or liver cirrhosis with varicosities who get pregnant. And same with respiratory failure, you get reduced ventral residual capacity, and then you often they have pulmonary hypertension and a secondary consequence of the respiratory failure, and you're just asking for trouble. So yeah, so simple things. So all organs are not working that well. When you're pregnant, they just don't do well. So yeah, so disease can adapt poorly to increased renal blood flow. Risks include particularly worsening kidney function and progression to end-stage kidney disease. You can get worsening hypertension, increased risk of preeclampsia, and then you get worsening proteinuria as well. The most important factor in determining outcome is the degree of renal impairment prior to conception. So that is the creatinine. But however, chronic hypertension, presence of proteinuria, and underlying renal pathology also matters. So as we just mentioned that already. Now, often, particularly in Reading, we've got a quite a bit of a refugee population, particularly the African refugees that are coming, who have been migrated here, and we'll come across this quite often. And also sometimes, women of childbearing age or generally health and fit and not often see the GPs often, and they come in and you might see they might initially present with a renal impairment at their booking. So anyone who's got persistent proteinuria, that's a PC of more than 50 before 20 weeks, that's ongoing persistent proteinuria, then often is underlying renal impairment that often coexists in about more than 50% of patients. And they often have chronic associated hypertension that's not been diagnosed. And these women are quite increased risk of adverse outcomes in their pregnancy, particularly progression to end-stage renal disease, particularly in 5 years. So it's very important to involve the renal team in those sort of situations. So in all these consequences, particularly you got renal impairment or heart failure, or liver failure, respiratory failure, it's very important to have preconceptive counseling if they wanted to get pregnant. Okay. So generally speaking, preconception counseling, CKD 1 to 2, they're generally fine as long as their blood pressure is stable or is normal, and they have no proteinuria. If deterioration is often noted in those who have hypertension, who have rapid change, progressive change, glomerulonephritis at the histological diagnosis. But generally speaking, they tend to do well. There is progression to more advanced stage renal disease in about 8% of women, but often it's reversible. Progressive decline only occurs in about 3% of women. And again, that's often more associated with the underlying histological diagnosis. For CKD 3 to 5, it's all dependent on the creatinine levels. Usually begins to rise above pre-pregnancy levels during the second trimester and often does continue to climb. So stages 3 to 4, the risk of reversible distration is about 25 to 40%, so quite high, and often can persist for about 6 months after delivery.
Jabba,
Sorry, hello.
I'm sorry, I don't think the slides are changing. It's still on pregnancy adaptation.
Oh my God, what's going on? I'm on CKD.
Now it's CKD 3 to 5.
I'm really sorry.
No,
I
that's
didn't
okay.
realize that. All right,
Thank
I've
you.
just gone back out. Can you see now?
Yeah.
Yes,
Right,
it's on
sorry,
it's
sorry, everyone.
CKD 3 to 5.
Sorry,
Thank you.
I didn't realize that. CKD stage 3 to 4, the risk of reversible dystrophy is about 25 to 40% in pregnancy. Often people have persistent renal impairment 6 months after giving birth in about 20% of cases. 10% of those people will go into end-stage renal failure. And then CKD5, the end-stage renal disease, before pregnancy are the greatest risk of accelerated decline in kidney function during pregnancy, just because they're already not working well. And they go to end-stage renal kidney disease, and often these people are already on dialysis by the time they found out to be pregnant. And we'll go on to why that is. And again, risk of women with moderate to severe kidney disease developing worsening of hypertension about 46%, as expected. You expect to see hypertensive disease in those with renal impairment. So this is the relative risk of reduction in kidney function according to pre-pregnancy serum creatinine level. So it doesn't matter. So hence why preconception counseling in improving kidney function before getting pregnant, improving proteinuria is very important. Improving blood pressure is very important before these women do get pregnant. So I'm gonna just move on. So what are the effects of renal disease on pregnancy? I can't really go out of the slides.
Okay, I can pick on people then. Let's
I'm gonna ask a kind of question, and maybe it's irrelevant.
Yeah,
I was
go for
wondering
it.
about earlier on, you were talking about the increased chance of fetal loss, and I wondered whether this was something that was like a vascular insult or is to do with the placental growth.
It's to do with actually what we're going to mention is to do with the urea. So
Oh,
urea, you got to remember the kidneys are clearing out urea. Urea is a toxic substance to our cells and our bodies. It can cause uremic pericarditis, myocarditis. So it affects our hearts. So urea at a level of more than 17 is a renal indication for dialysis, which we'll come on to mention in pregnancy or outside of pregnancy, particularly pregnancy, because a urea of more than 15 becomes teratogenic to the growing fetus. If it's more than 20, 25, there's going to be significant teratogenicity to being the fetus is going to be exposed to. So that's why we often consider dialysis early on in these women. So those are the areas. You do obviously get vasculature changes, particularly from the hypertensive issues. You do get sort of, microvascular disease that's going to be present. That's going to affect placental growth, placental function, sorry, and lead to RUGR baby. But in terms of the other renal element to it is that urea that you're not being able to clear. And we know that biochemically, your biochemistry, if you're pregnant, is going to be your baby's going to have similar biochemistry to you. So if you're hyponatremic, your baby's going to be hyponatremic. If you're hyperkalemic, your baby's going to be hyperkalemic. Same things apply because all those electrolytes cross placenta, urea crosses the placenta quite easily, and hence why there's a high risk of complications, as I mentioned. So we'll just go through. Oh, now everything's frozen. So there's a high risk of miscarriage because of that reason, and particularly second trimester miscarriages. You're more risk of anemia because your kidneys are not functioning that well, and then you got an increasing burden where the fetus is like a parasite. It's going to be using all your iron stores, and you're going to become more profoundly anemic. Your purpuration's not working that well, so your bone marrow is not working that well. You're going to get hypertension. You already have hypertension. You get superimposed preeclampsia, and then you get your growth restriction as a result of the hypertension. Preterm delivery, mainly iatrogenic preterm delivery, but also could be because of PROM, because there's a risk of polyhydramnios. So the polyhydramnios comes from the urea. So the baby will start to pass more urine because it starts to drink more amniotic fluid, and then you get more polyuria, and you get quite significant polyhydramnios, and that's associated with the degree of urea that the fetus exposed to, and then perinatal death as well, as we mentioned, from the urea. So management CKD. So what are going to be the important things you want to consider in terms of management of someone with renal disease who comes to see you, who wants to get pregnant? What's the thing that we just mentioned that's going to be very important?
To optimize their kind of kidney health beforehand.
Yeah, exactly. So preconception counts is going to be very important and optimizing the beforehand. So you want to get an MDT sort of involvement in this. So midwives, specialists maternal medicine, nephrologists in tertiary centers, and dietitians. The dietitians are very important. I spelled that wrong, sorry, because they they're going to need some electrolytes, certain replacement of certain things because often they're not getting enough of that, particularly phosphates and other sort of vitamins. Fertility is quite important, particularly a lot of the women are struggling to get pregnant because of hypothalamic suppression of the GnRH pulses. So if you got renal disease, quite really bad renal disease, people can become amenorrheic because they lose the hypothalamic drive in terms of GnRH pulsatile release to release FSH and LH, and which is why they don't ovulate, which is why they don't have periods, and then so forth. So often they may increase the fertility if they want to get pregnant as well. So to call it a plan. So preconception counsel again is very important. That's one thing to remember in any sort of person who has any sort of medical problem or medical disease. And the aim is to plan pregnancy safely. So you're optimizing kidney function, as you mentioned, proteinuria and blood pressure. Prior to them getting pregnant, you want to ensure they're on contraception before they get pregnant. So the last thing you want is an unplanned pregnancy, not unplanned from our perspective, probably planned by them because they want to get pregnant. But you want to make sure that things are in place to support them in their pregnancy. Make sure they're on high dose folic acid. In certain conditions, it may be advised to delay things until the condition stable. Particularly, you don't want to get getting pregnant on when you're having a relapse of a lupus episode because you're more likely to miscarry and have ongoing relapses in the pregnancy. It's important to consider a repeat kidney biopsy if remission status is unclear before they get pregnant, and then suppression proteinuria with medications such as ACE inhibitors or the alternatives are angiotensin reversal blocker, ARBs. I can't remember what they stand for, but angiotensin reverse blockers until attempting conception. So antenatal care. So what sort of things would you want to be putting in place in the antenatal care? So we talked about folic acid. Anything else you want to give them when you see them in clinic? Now this is where you've planned pregnancy. You're happy they're pregnant. Not well. You made a plan. They're pregnant. You now want to put things in place. What sort of things are you going to put in place in the antenatal care to support things to reduce the risk to them?
Aspirin.
Yes, aspirin. So you'll give high dose aspirin, so 150 milligrams, not high dose, so a low dose, but 150 milligrams once a day. Anything else?
Vitamin D, like you said earlier.
Yeah, exactly. So vitamin D is going to be important, and you want to check the vitamin D levels. Anything else?
Regular using-ease.
Yeah, how often would you do the using-ease?
Fortnightly.
Yeah, so you do them after every 4 weeks. So you do a baseline and then do them in 4 weeks. So I've come back to this slide just so to give you encourage your thoughts. So basically what you're doing is to minimize this. So yeah, using these are going to make if you look at the urea, make sure it's not high, things like that. Anything else?
Growth scans?
Yeah, how often you can do growth scans?
Would you say every 4 weeks? I guess the most often it can be is 2 weeks.
Yes, every 4 weeks. Yeah, so every 4 weeks. So you do them from every 28 weeks onwards, every 4 weeks. So you only do them every 2 weeks if there's concerns with the, for example, if you've got an SGA baby on board or an IUGR baby on board, then a 2-week growth scan is indicated because what you're looking for is when the Dopplers are becoming abnormal, particularly umbilical artery Dopplers. Prior to that, a 20-week scan with the 20-week anomaly scan, you will also do uterine artery Dopplers as well, just to make sure there's no high increased pulse index in there, because that will sort of predict which the risk of in terms of those who are more likely to get early onset changes in IUGI in those pregnancies. So anemia, anything you want to do about the anemia?
Oral iron supplementation.
Yeah, exactly. So give them iron supplementation. You might even give them epoetin as well. Okay. So yeah, so as we talk, it's MDT planning. You might want to get an early dating scan just so you can make sure there's no other concerns going, because you might get twin pregnancy and then it just complicates things even more. So your aspirin, 15 milligrams once daily, 5 milligrams folic acid, and you will continue that for the duration of the pregnancy. So not up to 12 weeks, you continue the folic acid because they need the folate for metabolism and growth, and also for to help red cell survival, basically. Vitamin D and other multivitamins, particularly B vitamins, are quite important. Often they're quite deficient in those. Iron replacement could be oral or parenteral. You wouldn't give any apoetin or parental iron in the first trimester. Just to be note, apoetin often can cause or aggravate pre-existing hypertension. Blood transfusions may be needed to maintain the hematocrit, and obviously in those situations you want to give CMV negative, according to rhesus status, and K negative blood. It's important to remember that a lot of our renal patients, particularly those who have pre-existing renal disease, particularly polycystic disease or glomerulonephritis, often may be on a waiting list for transplant. So you don't want to increase the risk of the red cell antibodies, because often these transplant patients have HLA matched donors just to reduce the risk of rejection. So they may ask that you give HLA matched blood, basically, for those who need blood who have renal disease. Antidote care targets blood pressure wise, you want to make sure they're well controlled. So targets of 140 of 90 is what they recommend in the TOG. The NICE guidance say less than 135 over 85 is what for preeclampsia and hypertension, but the 140 90 is mainly because if the patients are going to be on dialysis does cause quite significant hypertension. So you don't want the blood pressure to be too low. Preeclampsia bloods and urine PC and MCNS. So a lot of the patients are quite high risk of UTI. So you want to do the urine for a week, every month. Same with the bloods, as you mentioned. Now, diagnosing preeclampsia can be quite difficult in those who already have proteinuria. So often the S-FLIP-PLGF ratio is quite useful. Because if it's quite high, you can support, kind of help aid you in diagnosing if there is post preeclampsia. OGTT is definitely recommended at 28 weeks in these patients. Often they are on an immunosuppressant medication that does predispose them to GDM in their pregnancy. Some may even have diabetes already. And then obviously normally scans look for genetic conditions. So like, the reflex neuropathies that we mentioned, they may have a hydronephrosis, and then you go to scans. VT prophylaxis, now don't forget this, just because a lot of these patients already have nephrotic levels of proteinuria, and this is a risk factor of venous thromboembolism. Does anyone know why? Anyone? No? Okay. So basically you get, so if you think about nephrotic syndrome itself, you get increase, you're losing protein, so you're going to get more reduced, you're going to hyperviscous blood flowing. And also what happens is you do lose some of your clotting factors, particularly antithrombin, which is reduced significantly. And then obviously as a result, you're more likely to get clots. So these patients often do need venous thromboprophylaxis, and obviously a renal dose will be indicated if EGF is less than 30. We don't tend to do any renal biopsies in pregnancy just because we want to defer it till after they've given birth because of high risk of bleeding. But it may be indicated if there's nephroticism in the early pregnancy or suspected rapid progressive glomerulonephritis. Now, serum screening is unreliable, and so is non-invasive prenatal testing. So it's important that patients are aware and counselled about this. Okay, if there's any concerns, FMU review is obviously indicated to counsel these patients. And important to treat any asymptomatic bacteria because of recurrent UTIs, because the risk of UTIs in this population is quite significant and can have significant morbidity and mortality. Nutritional management, again, depends, refer to renal dietitian, and dialysis may be needed. So it's important to consider access. So you may need to get a Testio catheter line sorted, and a BAS cath may be needed while you're waiting a Testio. Formation of arteriovenous fistulas are not done in pregnancy just because you're more likely to bleed significantly, and it's done after delivery usually. So what are the indications of dialysis? We mentioned one already. What was the one that we just mentioned?
Urea over 15?
Yeah, over 17, yeah. Anything else? Think of your medicine days, guys.
Like hyperkalemia, that's not responding to...
Perfect, yeah, refractory to medical treatment, yeah. What's the other one? What comes with hyperkalemia? What's some other, so acid base, I just said it now anyway. Acidosis, severe metabolic acidosis, that's not, again, refractory to a medical treatment. Anything else?
Pulmonary edema?
Exactly. Anything else? So basically, you've done most of them already. So basic acute deterioration renal function is the other one. So your severe refractory metabolic acidosis, hyperkalemia, volume overload, so congestive cardiac failure, pulmonary edema not responding to diuretics, acute deterioration renal function, and high uremia. After people get this uremic pericarditis as well at times. Yeah. So in terms of mode of birth, intrapartum care, what things would you want to consider? Can they have a vaginal birth?
They could. I was going to say maybe fluid management.
Yeah, fluid management is very important. They can have a vaginal birth. Anything else? Say if someone's on immunosuppressants, what might you want to give them in their labour? Say someone's on prednisolone, would that be concerning?
Would you swap it to hydrocortisone?
Yes, so you continue the prednisolone and you give them some hydrocortisone. So they're high risk of adult crisis, particular stresses of labour. So if anyone's on any antenatal steroids, particularly 5 milligrams of prednisolone or more, for more than 3 months, you need to give them hydrocortisone cover during the labour. So 50 milligrams every 6 hours until 6 hours after delivery. Again, for those who are having a cesarean section electively, give them some hydrocortisone as well. There's no contraindication to vaginal birth. Often these women will have a planned industrial labor usually near 37 weeks, as often they have preeclampsia or worsening blood pressure or renal impairment anyways. Cesarean sections for obstetric indication. Again, fluid management is very important just because these patients are quite high risk of overload in their labor. So postnatal, anything you want to consider? What did we just mention in the antenatal care that was quite important in those with proteinuria?
VT prophylaxis.
Exactly. Anything else in preconception counselling that we mentioned?
They're like proteinuria, like putting them back on, or whether they can go back on medications and breastfeed.
Yeah, so you might want to put them, yeah, good. Well done, Ebs. So you might want to put them on ACE inhibitors. That might help with the proteinuria. So you might give them captopril or enalapril. Anything about pregnancy, stopping, we're talking about preconception, contraception. Okay, do not forget contraception. That's one thing to do. This because, again, as we mentioned, often people have ongoing renal impairment that can persist after giving birth, or may even progress to end-stage renal disease. So you don't want them getting pregnant soon after. So generally speaking, contraception wise, the Mirena IUD is perfectly fine. You would generally avoid a combined oral contraceptive pill just because it's a Met criteria 3, so the high risk of venous thromboembolism, that's the main reason. But generally speaking, the others are Met criteria 2, so they're quite fine to give. So women on chronic dialysis, I'm just going to get through this just because it can be quite difficult to grasp. So basically, fertility in people with chronic dialysis is going to be quite significantly reduced because they often have got significant hypothalamic reduction in GnRH pulsatile release. The outcomes are generally poor. We hardly see any women who are on dialysis getting pregnant or having successful pregnancies. But however, successful pregnancies are better if they are go to an intensive dialysis regime. They do have poor prognosis factors, particularly if they're more than 35 or already been on dialysis for more than 5 years or late booker. In these sort of situations, renal transplant is the only thing that's going to be the best thing for them. So pregnancy outcomes are generally poor. Pregnancy is lower in women with peritoneal dialysis versus hemodialysis. The main reason is because often those who have peritoneal dialysis often have quite significant lesions in the abdomen, and the quite significant sclerosis that does happen, and they might have some tubal damage as a result and may not be able to get pregnant for tubal issues as well, and they have high rate of ectopic pregnancy when they do get pregnant. Spontaneous miscarriages are common. 21% only reach the second trimester. That's quite significant compared to those who have transplant, where it goes up to 95% of them have successful pregnancies after first trimester. Preterm birth is common. Mean age is about 32 weeks. Again, that's associated with maternal complications and often iatrogenic. Prematurity contributes to low survival rate in these sort of in the babies, and survival rate is about 30 to 50%. And again, they have other high maternal complications, and 50% end up having cesarean section. Anti-nutrition, as previous as we mentioned, the additional things on nutritional management is far more important, just because of the dialysis fluid that they're using. Often it's quite they got adjusting them. Often patients are have quite low or high phosphate levels. Again, vitamin B, C, and vitamin D are going to be very important, and folate. Lipoprotein is generally increased, and we get iron supplementation is given for those who have iron stats less than 30%. To improve the success rate of pregnancy, generally speaking, the frequency of dialysis has to increase. So that's 20 hours per week. So that's a significant. So often you've been dialyzed every 5 to 6 days every week, basically for 4 hours. Target urea periodic is less than 15 to 20. As I mentioned, we'd want to any higher, we're more likely to get teratogenicity above 20, generally speaking, more than 17. Risk of maternal hypertension and bone depletion is quite significant. So blood pressure control is very important, 80 to 90. I've seen people being on dialysis who've basically end up going dialysis and then end up having a massive stroke because they became so significantly hypotensive. So it's very important that, these are patients that you're managing blood pressure and not aiming for too low blood pressures, just because the risk of watershed infarcts. Peritoneal dialysis is safe to continue pregnancy, but extraneous risk increases in the main distribution of hemodialysis as the uterus enlarges or if cesarean section is needed. So renal transplant pregnancy, generally speaking, they do well. Kidney transplants rapidly restores the ability to conceive within a few months, and women are likely to conceive within transplant than on dialysis. So generally recommend improving the function. If they are if they can have a kidney transplant, they are late in this, probably best to get the kidney transplant first and then attempt pregnancy afterwards. But it's important to advise contraception once they have had the transplant, just for at least for the first 2 years. But you can safely get pregnant after 1 year after transplant. The main reason for that is because of the increased risk of rejection. A lot of women who have transplant, obviously, remember, it's a big lifestyle change. You're having to take immunosuppressants daily, and often there's a narrow therapeutic range with those targets need to be with targets of the immunosuppressant. So often we do see high risk of rejection, particularly in the early stages of transplantation. And patients will on lifelong immunosuppressants, so they will need to be changed to other medications that's safe in pregnancy, and other dosings increased as well. So after renal transplant, miscarriage is similar to the general population, so 94% end up with successful pregnancy after the first trimester. Similar rates of congenital abnormalities as the general population. Ectopic rates are high, mainly because you've had patients might have had surgery, and also patients might have had previous history of peritoneal dialysis. The important thing to note is the opportunity infections that may affect patients with renal transplants, so rubella, CMV, toxoplasmosis, and Hep C. Often patients who have chronic disease are vaccinated against Hep B, and generally they often get their MMR vaccine done beforehand as well, because we know once you are immunosuppressed on transplant, you can no longer have sort of live vaccinations because of the risks to you. And we know CMV and toxoplasma and rubella have significant consequences for the in terms of teratogenicity and fetal abnormalities for the babies. So it's important to look for those, and we do titers and check for these every month, so every trimester in people with transplants. UTIs are common, 40%, and often they do get quite quick acute bacterial pyelonephritis. Again, monthly testing of urines is quite important, treating any bacteria. Essential hypertension is still quite common even after transplant. You got to remember that even though they're having a transplant, they are not removing the diseased kidney. So they will have some renal sort of superimposed preeclampsia because of that reason. GG risk is also high, and often people develop this new onset diabetes after transplantation, and this is medication related. Often people go on calcineurin inhibitors, which are like tacrolimus and cyclosporin, which are quite good immunosuppressants for people on transplants. What they do, however, do is cause apoptosis of islet cells in the pancreas, so you do get so you do end up getting some diabetes after that, which is not ideal. So it's one of the consequences of medication, so it's something to be mindful of. Preterm birth and PPROM are common. Fetal growth restriction affects about 60% of patients, as they often do have essential hypertension, and they're at risk of graft rejection, as we mentioned, particularly in the first month first year after transplant, and mainly because when in pregnancy you do need to increase the doses of certain immunosuppressants, particularly the tacrolimus or cyclosporin, and often if they are not within therapeutic range, they are predisposed to obviously auto destruction from our own bodies. So as with chronic kidney disease, pregnancy outcome depends on serum creatinine, protein, and hypertension. So immunosuppression wise, which ones are safe? Or which one isn't safe, I should say? Hello, anyone there?
I was thinking, is it tacrolimus? I can never pronounce.
Are we saying it's safe or isn't safe? Let's start from the top. Prednisone, is it safe in pregnancy?
Yeah.
Yeah. Okay, just shout everyone. Just shout. Azathioprine, is it safe in pregnancy or not?
Yes.
Yeah.
Yes, it is. Yes. Tacrolimus, is it safe in pregnancy?
Yeah.
Yes, it is. Cyclosporin, is it safe in pregnancy?
No.
No.
Yes, it is. It is safe. You can use it. It does have, of course, significant hypertension, so we often tend to go with tacrolimus. But tacrolimus and cyclosporin are the same sort of drugs in terms of mechanism of action. They're both calcineurin inhibitors. Mycophenolate mofetil, MMF.
No.
No. But I
No,
don't
yes, that's a no. That's a no. Yeah. Sirolimus and everolimus.
Never heard of those.
The
No,
BNS says no.
Yeah. Yeah, so mycophenolate mofetil is unsafe. It's associated with malformations, particularly ear, cleft palate, and lip, and it's can cause first trimester pregnancy loss. There's little evidence of sirolimus and everolimus, so avoid breastfeeding is unclear, but generally speaking, azathioprine is safe in breastfeeding. Sanitary management, same as chronic kidney disease, MDT, aspirin, folic acid, all that jazz, serial scans, all that jazz. The only thing that's different is that you are testing for those opportunistic infections, CMV, HIV, herpes simplex virus, Hep B, and all the extras, just to make sure there's no risk of them getting those infections because they are high risk. If they're CMV negative, you test each trimester. If they're positive, you check the titers. Often people can get this sort of prodromal infections with CMV and often get quite bad diarrhea and abdominal pain. But again, this has significant consequences on the fetus as well in terms of congenital abnormalities. Again, oral glucose tolerance tests, as I mentioned, and hypertension management. Now, neonatal is very important just because there are immunosuppressants. So often babies have thymic atrophy, can have transient leukopenia and thrombocytopenia. So they get this like bone marrow suppression sort of thing that develops, and adrenal cortical insufficiency. So it's important that a neonatal alert is made and the baby's bloods are checked at delivery. Often cord bloods might be taken just to sort of help ensure that the platelets and everything else is normal, basically. Graft rejection in pregnancy occurs about 9 to 14% of women. Incidence episode rejection is quite low, about 5%. But generally, it's more common in the first trimester. So the first year of transplant. And compliance to immunosuppressive therapy should be ensured, particularly in those patients. And patients can often be asymptomatic with those graft rejection. But they often do get some features, particularly deteriorating renal function. If you're wondering what's going on, why is the creatinine going up? There's no other cause for it. If they've got fever, oliguria, and graft tenderness or swelling, it most likely is a rejection. And we often do see, particularly in a younger women who are basically who've had renal impairment to begin with and have a transplant, say in the 18 or 20s, they often are those high risk to get rejection just because of the whole lifestyle change in terms of taking immunosuppressants daily and having regular blood tests done and lack of compliance basically with medication and follow-up. So AKI in pregnancy, so near this home stretch, sorry guys. So AKI is acute decline in kidney function. It's associated with more than 20% rise of serum creatinine, and most commonly presents in postpartum period and non-pregnant patients. As we know, it's associated with increased morbidity and mortality, and 40% of AKI goes unrecognized. So what are the common causes for AKI in pregnancy?
Jabba, just hold on a second. Vinod, you had your hand up. Do you want to ask something?
I had to go back.
Yeah, quick question. So in people undergoing renal dialysis, they do need extra hepatitis B vaccination. So is that true also for the COVID, that for their primary series that they need more than 2, so 3 doses of COVID?
So people who are, so you're basically more risk of infection. So you will give them normal vaccinations and you will give them booster. So because they're a high risk population, that's why. Are you talking about COVID vaccination or Hep B?
Both. I was just using the Hep B as an example.
So yeah, so you know how
exactly.
So you know how we get our boosters every 5 years. Well, we're supposed to, for Hep B. The same sort of thing applies to those who are renal disease and transplants, because we know our immune system so does lose memory. So we need to make sure that we do update those vaccinations, and particularly transplant patients that you're having quite a lot of intravenous accesses. You might even give blood to them as well. So you need to have those sort of make sure they're appropriately immunized. But obviously, live vaccines in transplant patients is contraindicated just because they're immunosuppressed and they're more likely to get a florid reaction to it or infection with it. COVID-wise, we know it's not a live vaccination, so they will all get the booster and would have had the boosters, I hope, if they were pregnant as well or non-pregnant. Oh God, I'm seeing all your messages now. I'm really sorry. All right, I'm going to go back to the screen. Is that okay? Can you see the screen now?
Yeah, we can see it fine. Thank you, Jabba.
Right,
yeah.
okay.
That was
So
one.
So what were the causes for AKI in pregnancy? Anyone?
Could be just hypovolemia, not keeping up with drinking.
Yeah, hypovolemia. What's so hypovolemia? What can happen in pregnancy that can cause hypovolemia?
Hyperemesis.
Yeah. Any bleeding in labor? Anything? PPH, an abruption can cause hypovolemia. So let's proceed. So pre-renal, renal, and post-renal. So pre-renal, we talk about hypovolemia. Anything else pre-renal? Okay, we'll move on to renal then.
Yeah.
Anything renal?
Preeclampsia.
Yeah, preeclampsia.
Any new drugs that might like pain medications or opioids? I don't know.
So your NSAIDs, opiates. So opiates, generally, you got to move back for clearance of opiates. Sorry, Emma's trying to dictate while I'm talking. Yeah. Okay, I'm gonna help you out. So pre-renal, we talked about volume contraction, hyperemesis, blood loss, infection, sepsis. So don't forget your sepsis. NSAIDs can affect afferent blood flow to the kidneys. Same with ACE inhibitors. As you know, ACE inhibitors are contraindicated in pregnancy because it's teratogenic. Intrinsic renal disease, you've got AKI associated placenta dysfunction and thrombocytopenia. So those are going to be your PET, HELP, thrombotic thrombocytopenia purpura, hemolytic uremic syndrome, your acute fatty liver of pregnancy, and the drugs, and the glomerulitis, as we mentioned, and the post-renal causes. Now, one of the post-renal causes not there is actually, I would say, obstructed labor. So we don't commonly do euthanasia in pregnancy, in labor. We do them more often now because we're recognizing the significant impact of hyponatremia on in labor and particularly on the fetus. But one thing you do notice is that particularly people who have been in labor for some time who failed to progress or got obstructed labor, they often have got a significant AKI and often above the hundreds at times. So it's commonly something we're seeing more now, I would say, because we're doing more euthanasia. So that's something that can cause post-renal AKI. Particularly when the midwife's asking, oh, she hasn't passed much urine, he's giving her more fluid and nothing's coming out, it's because they're obstructed, basically. And then you got your other obstructions. So AKI in pregnancy, any creatinine more than 90 is diagnostic of AKI in pregnancy, and it complicates about 1.4% of UK obstetric admissions. Okay, so it's very important to know. And the more than one cause can coexist, particularly if you've got preeclampsia or HELP on board at the same time. Preeclampsia is the most common cause, about up to 2% cases have AKI, but you often see it more commonly in people who have HELP syndrome. Most cases have pre-existing renal disease, as we mentioned. Investigations, what would you do? We nearly near the end, guys. Come on, push through.
So I suppose your investigation would be dependent on what you think is causing the problem. So initially you look at the UNEs and you've detected it. If they've got any other electrolyte disturbances, like problems with their sodium, maybe you could do like urinary sodium.
So you could osmolarities and things like that, yeah. You can do a venous blood gas, check the acid-base status. As we know, kidneys are very important. And after you do get you might get a bit of acidosis, check for urine dip, ultrasound scan if it's indicated, and then just blood test, particularly if you're considering it's preeclampsia or HELP, etc. Okay. Management-wise, what would you do? I need to pick out some names.
Depends what's the cause, because obviously if it's PET, you don't give them loads of fluids.
Exactly.
But if it's dehydration,
you do. Yeah. So treat the underlying cause basically. Oh, has it frozen? Treat the underlying cause, food management depending on what the cause is, medication adjustments. So don't forget to adjust your dosages if the EGFR is less than 30. So that includes your opiates, your enoxaparin, fragment, inspirin, whatever you want to call it, lomocriptine, your insulin as well. Insulin is renally cleared. So if you're given the same dose of insulin, people have got AKI, they're going to have a profound hypoglycemic event. Correct the hyperkalemia. Often you do get, with AKI, can get some element of hyperkalemia. And the renal replacement might be indicated if it's quite severe AKI. And again, urea more than 70 is tragenic, and it's a pregnancy to get for renal replacement therapy. Okay. So we're going to get some case presentations. The last bit of the presentation, I promise. Three case presentation we're done. So patient A is 28 weeks pregnant, who's attending maternity triage unit with the headache and abdominal pain. Her blood pressure is 160.8, as you can see, and it's got proteinuria. So what are you all suspected? Just shout out, please.
Preeclampsia.
Cool. Okay. What are you going to do next? We're going to ask the midwife to do what investigations are going to do, what baseline tests are bedside tests are going to do. Shout out.
PCR.
Blood, CTG.
Yeah.
Hypertensive.
Yeah. Good. Anything else?
Growth scan.
Yeah.
Well, not urgently, but yeah.
Yeah. So there you go. So you don't CTG, it's normal. You commence an antihypertensive, and the blood pressure is 140/92. Her PCS is 450, and the bloods have come back. The midwife has already done all the bloods before she got you to see the patient, and those are her bloods. So what are you suspecting now?
HELP and an AKI.
HELP, yeah, HELP syndrome. So what are you going to do next? How are you going to manage this? She's 28 weeks, and she's got severe preeclampsia with HELP syndrome. What are you going to do? What other treatment are you going to give her?
Mag sulfate.
Good. Now, mag sulfate. What loading dose are you going to give her?
4 grams.
Good. And then what's the maintenance dose?
Oh, I didn't know that.
So are you going to give the normal maintenance dose? Are you going to give increased maintenance dose or reduced maintenance dose?
We have to be careful because of this AKI.
Yeah. So how much maintenance dose are you going to give her?
Less.
A reduced maintenance, yeah, less. So you're going to give her half of the dose. Anything else? She's 28 weeks. And you're giving her mag stuff. If you're giving her mag stuff, what are you planning to do? Deliver her, aren't you?
Steroids.
Yeah, exactly. Steroids. There you go. So you're going to give her steroids. You're going to give mag stuff. So just a key note: if the creatinine is more than 90 or the urine output falls less than 20 mils per hour, then you need to fluid restrict 80 mils per hour anyway. You would do about 85 mils per hour, and then reduce mag stuff dose to about 50%, so 0.5 grams per hour. The loading dose does not change. Okay, so even if they have another fit. If they have a fit, you give the 2 grams. You don't. Is it 2 grams? Yeah, you do give 2 grams. You don't change the loading dose. Okay. So it's so PET and HELP, as you mentioned, PET may be more common cause of AKI, but highest of AKI in those with HELP syndrome, 3 to 50% of cases. Clotting abnormalities are more common in HELP syndrome when you differentiate it between those who have thrombocytopenia purpura or hemolytic uremic syndrome. So patient K, so we've seen A and now we're on K. She's 36 weeks pregnant. She's been seen by your F2, who's admitted her because she's got nausea, vomiting, and she's got raised ALT, and they're suspecting some gallstones. Oh my God, is that a dog? What is that? Is everything okay?
The joys of virtual teaching.
All right, patient supportive management is so basically going back to the sorry. So they're suspecting gallstones. So they're managing patient supportively with some fluids. She's upstairs on the antenatal ward. awaiting ultrasound scan of the liver. And the midwife calls you, saying the patient's confused and increasingly drowsy. What are you going to do? Come on, guys, shout out anything. What are you going to
begin with an A to E assessment?
Yeah, good. So what are you going to do in A? You start A to assessment. You can't just say A to assessment.
Oh,
and then hope for the best. You.
Hey,
Anyone help out? Anyone shout out things? Come on. We're near the end.
Airways. Check their breathing.
Yeah. So they responding to voice only. So the airways is secure, but it's it's not going to be secure for long. Yep. Go on to breathing. So breathing, she's they're a bit restless. The breathing is about 20, say 26.
That might kind of suggest maybe they're trying to breathe off CO2.
Yeah, they are burning off CO2. They're trying to compensate, aren't they?
Yeah.
So what else is going on? Well, so you go to see the heart rate's about 80, blood pressure's a bit borderline. Let me just skip past. So yeah, so you've done some few things, okay? She's done some bit of some bloods for you already. She's so good. She's done everything for you. Blood pressure's 140/80. They kind of get a urine sample for the patient because she's drowsy, responding to voice only, and she's quite clammy. But you do know the creatine's 95 and the blood's done on admission, and that wasn't handed over. Often the case, isn't it? We don't always, not all of us knows what a normal creatinine might be in pregnancy, but she's got an AKI, hasn't she? So what more things what are you going to do? So you can repeat. So what other bloods are you going to do? So she's done bloods off. What bloods are you going to make sure that they've done?
An ABG.
Yeah, an ABG will be really useful. Yeah. Anything else?
I'm sure you know what the urea is, and the using these particularly.
Yeah. Any other blood tests that's going to be important?
Cultures potentially if she has gallstones.
What was that? Sorry.
Blood cultures.
Yeah, cultures. Yeah, sepsis can cause clotting is going to be very important. Yeah.
Clotting and group and safe.
Yeah. Anything else?
FBC.
Okay, so let's go back to the A, B, C, D, E. Okay, so you've done A, B, C, D, and D, you got disability. So you look at glucose. Thank you. Did someone say glucose? I don't know. Did someone say glucose? Yeah, fine, good.
Yeah, I said
glucose. Yeah, thank you. But you will get that in your ABG, but I just want to make sure you emphasize it. So those are the labs that's come back. They've also sent a serum ammonia, but it got rejected. It was not sent on ice. So back in the day, we used to do a serum ammonia, and if you did send an ice, it's get rejected by the labs. Anyway, so that is her blood. So what do you think is going on now? Her creatinine's now 250. Oh God, and the ALT is 350. So she's got some hepatorenal issue going on, and some
fatty liver pregnancy.
Yeah, acute fatty liver disease of pregnancy. Do you know why?
Well, clinical picture, but her glucose is really low and her liver is through the roof and her coags are abnormal. So
yeah, and exactly. So bilirubin is low, and so you basically get lactic acidosis as well with acute fatty liver, and you get quite high prolonged PT and APTT and profound hypoglycemia. So how are you going to?
Can I just ask, what was her presentation? Why was she admitted?
She was admitted with nausea, vomiting, with raised ALT, suspecting gallstones.
So remember, with fatty liver, I mean, it's so rare, but they get excessive vomiting, don't they?
Yeah,
so
quite excessive vomiting. Yeah. But you didn't see them. Your SHS saw them, but then all of a sudden they're more profoundly confused and drowsy. So how would you treat this? Anyone shout it out? What would you do?
Get all of the seniors involved.
Yeah, so you want to get MDT involved, you don't want to manage this alone because it's quite high risk of mortality. So AKI is common, so it's a high risk of mortality. So particularly aggressive, the severe coagulopathy, and also the fact that their airway is not going to be quite secure, and they got quite profound hypoglycemia. These patients, have high significant mortality and even might need a liver transplant. So it's quite important to get a lot of people involved, involved. So yeah, so AKI is common complication in acute fatty liver disease. You often see in 40% of those who have renal impairment, which is why I said the ALT and then looked at the creatinine. AKI was slightly there already. 3.5% need renal replacement as well. So it's characterized by profound hyperglycemia with low bilirubin levels, raised serum ammonia and lactic acidosis, and the hyperventilation is then trying to compensate for the acidosis that they've got on board. And the vomiting, polydyspepsia, and malaise because they have quite profound vomiting, and it's aggressive treatment of coagulopathy and hyperglycemia, and then deliver the baby basically.
Can I ask a question?
Yes, sorry.
What kind of time frame do you have to get them a liver transplant if that's what they need? Do you know?
So,
is this like down the line after they've recovered?
It's down the line after they recover. So often they don't. Often the liver can be so badly impaired that it doesn't recover that well, and they're quite confused and encephalopathic. So if the liver is deteriorating, they're getting more evolving coagulopathy, then you might need to transfer them to a liver centre, and that does often happen. And when we were in Manchester, they used to transfer them to Leeds, which was the liver centre that they had there. And they often had transplants, liver transplant, which if it wasn't correcting itself after delivery, and despite aggressive treatment of coagulopathy and hyperglycemia, the liver just wasn't working at all. The only way to save their life is to obviously give them a transplant. Okay. So patient I has already been discharged. That's the end. All right. So in summary, just remember MDT and preconception counselling is great importance with those with chronic kidney disease. Basic function, protein and hypertension affects the overall outcome in women with chronic disease. Don't forget your VT assessment, treat infections. Women are high risk of quite poor obstetric outcomes. And just remember, AKI is common and often overlooked in pregnant women, particularly those with preeclampsia and help in acute fatty liver disease as well. And treat the underlying cause and review medication. And just don't forget contraception postnatally. All right, that's the end. Sorry, guys. I know it's quite intense, the topic of renal disease. You've had a long day.
Thank you very much, Jabba. Any questions for Jabba?
Thank you so much. That was really good, Jabba.
It was awesome.
Thank you.
Thank you.
You can send me some CBDs. I'm sure